HOD, Department of Pharmacology, Dr. A.K. Vishwas sir, respected Professor Dr. Manoj Kumar Gurti sir, Professor Dr. Deepa Mishra ma'am, respected Professor Dr. Shubhashish Sarkar sir, and all the students of second year MBBS, SGLT-2 Medical College, HAZARIBAGH. Today's seminar topic is Oral Anti-Diabetic Drugs, SGLT-2 Inhibitors. I, NEHA GUPTA, student of second year MBBS, under the guidance of Professor Dr. A.K. Vishwas sir, present this seminar. Diabetes mellitus is made up of two terms. Diabetes, coming from the Greek word meaning to clear or siphoning, and mellitus, meaning sweet or honey. Diabetes is one of the first diseases described in the history, meaning too great emptying of the urine. Indian physicians classified it as madhumeh or honey urine, noting that the urine would attract ants. Effective treatment was developed by two Canadians, Frederick Banting and Charles Best, in 1921 and 22. This blue circle is the universal symbol of diabetes mellitus. Now we will deal with SGLT-2 inhibitors. These are a new drug class that address hyperglycemia by reducing renal glucose reabsorption, increasing urinary glucose excretion, and consequently reducing serum glucose levels. These are the newest class of drugs that can be considered for addition to the combination of oral antidiabetic regime. These medications modulate sodium glucose transporter proteins in the nephron. Some of the examples are dapagliflozin and canagliflozin. This drug induces glucosuria, lowers blood glucose level in type 2 diabetes mellitus. This SGLT-2 inhibitors work independent of insulin, both secretion and sensitivity, which makes this class of drug novel and potentially complementary to the most current diabetes therapies. Mechanism of action of this drug. Practically all the glucose filtered at glomerulus is reabsorbed in the proximal tubules. The major transporter which accomplishes this is SGLT-2, whose inhibition induces glucosuria and lowers blood glucose in type 2 diabetes mellitus. It also causes weight loss. Here, in this diagram, we can see that SGLT-2 is responsible for 90% of the glucose reabsorption in proximal tubules, whereas SGLT-1 is responsible for 10% of glucose reabsorption, which is present in intestinal glucosa. So, glucose reabsorption is more than 180 gram per day, and urinary glucose excretion is 0.5 gram per day. On SGLT-2 inhibition, glucose reabsorption is reduced from 180 to 100 to 130 gram per day, whereas urinary glucose excretion is increased to 50 to 80 gram per day, which results in reduction in blood glucose serum level. Here we can see in the diagram SGLT-2, this protein is responsible for glucose reabsorption. On its inhibition, it reduces the blood glucose level by inducing glucosuria. It also reduces hyperuricemia. It reduces body weight. It decreases the blood pressure. It also decreases insulin resistance, arterial stiffness, and also reduces the blood glucose beta cell glucotoxicity. When glucose crosses renal threshold, it becomes toxic to the body, and that term is called glucotoxicity. Glucotoxicity results in reduction in insulin secretion and increase in insulin resistance. If sugar level can be lowered down below the renal threshold, glucotoxicity will be no more, and this class of drug, SGLT-2 inhibitors, act by inhibition of urea, and this reduces the blood glucose level in the serum. It is taken daily. After once daily dosing, it produces round-the-clock glucosuria. It is used alone or it can be used in combinations, and they are responsible for reduction of HbA1c level by 0.5 to 1%. It doesn't cause hypoglycemia. SGLT-2 inhibitors increase circulating ketone bodies, and these ketone bodies are responsible for the cardioprotective effect. SGLT2 inhibitor drugs are also anti-hyperlipidemic, anti-atherogenic, anti-obesity, anti-neoplastic effect in vitro, preclinical and clinical studies. There are currently 3 SGLT2 protein inhibitors. Canagliflozin was approved by the USA FDA in March 2013. Dapagliflozin in January 2014 and empagliflozin in August 2014. Among all of these, empagliflozin has the highest selectivity for SGLT2 inhibitors. Medical uses. The 2022 AD standards of medical care in diabetes include SGLT2 inhibitors as the first-line pharmacological therapy for type 2 diabetes mellitus. Second, a systemic review and network meta-analysis comparing SGLT2 inhibitors, GLP-1 agonists, and DPP-4 inhibitors demonstrated that use of SGLT2 inhibitors was associated with 20% reduction in death. A meta-analysis including 13 cardiovascular outcome trials found that SGLT2 inhibitors reduce the risk for 3-point MACE, that stands for Major Adverse Cardiovascular Events. Pharmacokinetics of this drug. Canagliflozin has bioavailability of 65%, protein binding of 99%, and its T-half is 10 hours, whereas dapagliflozin bioavailability is 78%, protein binding is 91%, and T-half is 12 hours. This drug is excreted in urine as inactive metabolite. Some of the interaction of this drug. Gliflozin appear to increase the diuretic effect of thiazides, loop diuretics, and other diuretics. It may increase the risk of dehydration and hypotension. Interaction with sulfonylurea have led to severe hypoglycemia, presumably due to cytochrome P450. Contraindications are patients with renal insufficiency. Adverse effects of SGLT2 inhibitors. First is genital candidiasis, which is the most common. Second is urinary tract infection, electrolyte imbalance, ketoacidosis, increased urine frequency, increased risk of lower limb amputation, corneal gangrene, acute kidney injury, and some of the symptoms of ketoacidosis include nausea, vomiting, abdominal pain, tiredness, and trouble breathing. Management of diabetes. First is lifestyle modification. Second, exercise. Regular exercise may improve the blood sugar control, decrease body fat, and decrease body lipid levels. A proper diet. A diabetic diet with calorie restriction, intake of fruits, vegetables, reduced saturated fat. Fourth is stress management. Fifth, medication. And the last is